it's really, really hard to hear. All right, so I'm Kyle Kampman. By way of introduction, I walked in here on July 2nd, 1990 as a resident in psychiatry, did my fellowship, and never went home. Been there all my time. And these three words have had a profound impact on the last 25 years of my life. And they were spoken to me by my research mentor, Joe Bopicelli, on the second day of my fellowship. I sat down in Joe's office, and Joe said, Kyle, you want to study psychotherapy or medications? Medications, easy. Okay. Kyle, do you want to study alcohol or cocaine? And I knew all about Joe and Chuck's work with naltrexone, and I was really excited to be an alcohol researcher. And Joe said to me, and I said, alcohol. I said, how about cocaine? And so I am, in my mind, mainly a cocaine researcher, turned alcohol when the money was there for alcohol, turned opiate researcher, and then that happened. So that is how I got to where I am today. And
I've never heard that bit yet. That's really interesting.
I especially want the fellows and the postdocs to hear that, because someday your mentor may give you a suggestion that just doesn't sound right to you. Keep an open mind. All right. Anyway, as I said, I started life as a cocaine researcher. I do clinical trials. Done a lot of clinical trials for cocaine and a lot of failure. In fact, I think if I could claim to be an expert in anything in this business, I am an expert on what not to do in the design and conduct of a clinical trial. I have made every mistake you can imagine, but I've gotten better. And some of the successes we'll talk about today, my really one and only success would be topiramate for the treatment of cocaine use disorder, plus or minus amphetamine. I've done some work with cocaine biomarkers. Again, due to the great generosity of researchers like Chuck and Joe and Arthur Alterman, George Woody, Tom McClellan, I did a lot of work with cocaine withdrawal syndrome, and we'll talk about that. And then currently, the most recent clinical trial that we have up is metirapone plus oxazepam for cocaine use disorder. So I'll talk about that. Then at the very end, I'm going to talk a little bit about the rapid detoxification protocols, trying to get people onto injectable naltrexone faster. And we'll finish up with that. Okay, just to remind people, drug use does not begin and end with opiates. Despite what you hear on the news, there are cocaine users out there, and cocaine users hurt themselves. This slide just happens to show that mortality rates from cocaine overdose far exceed mortality rates from opiate overdose in African American men and women. In European Americans, of course, we have much more overdoses with opiates compared to cocaine, but in our population here in West Philadelphia, African American cocaine users, people die from cocaine, and we really shouldn't forget that. And that epidemic will come back again, and so we still need medications for the treatment of cocaine use disorder. Now I throw this slide up. This is a simple doctor's cartoon of the mesocortical limbic dopamine system with dopaminergic neurons living in the VTA and projecting here to the nucleus accumbens with glutamate projecting back, and some GABA feedback back here in the VTA. And I put this up because I want to talk about the targets that I looked at, topiramate and amphetamine. When I first started doing this, we had a real simple-minded doctor's approach to this. Cocaine increases dopamine release in the nucleus accumbens. Well, hell, we can block dopamine receptors right here, and we did, and it didn't work. Now, Anna Rose has actually taken that a step further and looked at D3 receptors with a partial agonist and may have some efficacy there, but believe me, I failed a bunch looking at that. Now, interestingly, the opposite approach, a dopamine agonist, a medication like long-acting amphetamine or even long-acting methamphetamine given chronically to cocaine users will make the cocaine high significantly less, will alleviate cocaine withdrawal, and actually has some pretty good evidence that they may work. So you got that going for us. Topiramate. Why topiramate? Anna Rose had a lot of work done with a medicine called baclofen, which was a GABA agonist, which appeared to have a lot of promise. So I literally went to Medline and looked up GABA agonists and found that topiramate was a GABA agonist. Sent out to the pharmacy to get some topiramate and started looking at it. So we thought topiramate would affect GABA activity here, shut off dopamine, reduce the high people got from cocaine, maybe reduce some some of the excitement they got from conditioned cues. It just so happened that topiramate also has effects in the glutamate system, specifically blocking kainate receptors here in the nucleus accumbens, which may also have some effect on how it works in controlling conditioned reminders and the excitement people get from being exposed to reminders of prior cocaine use. So topiramate, glutamate, and GABA, plus minus, and long-acting amphetamine has been the target that has been most successful for me. Having said that, I'll tell you, topiramate, first trial we ran was a really teeny tiny pilot trial. 40 subjects, ran it for 12 weeks. Took a long time to get that topiramate dose up. People who've ever used topiramate know that it has lots of side effects, and the only way to reduce side effects from topiramate, besides lowering the dose, is to actually give it very gradually and let people get used to it. So it was a 13-week trial. It took up to week 8 to get people to the full dose of 200 milligrams of topiramate. And what we found was, if you looked at abstinence rates, continuous abstinence from weeks 8 to 13, we had a really nice topiramate effect. Very nice effect. Again, teeny tiny pilot trial, so we had to replicate that. So we did. By the time we got around to the replication trial, some of Hank's work and Bankole Johnson's work on topiramate for the treatment of alcohol use disorder was out there. So NIAAA and NIDA put out an RFA, combined RFA, looking for joint treatments for cocaine and alcohol dependence. For those of you who don't know, about 2/3 of the cocaine users that come to us for treatment are also alcohol dependent as well. So it's a very common combination of diseases, and so we looked at topiramate for the treatment of combined cocaine and alcohol dependence. Ran a trial, a 12-week trial, as we always do, had a slow dose titration of topiramate, and looked again at end-of-study abstinence. That is right now the FDA preferred outcome for our cocaine medication trials, which is a period of abstinence at the end, sort of a quit rate for cocaine, so to speak. What we found in our 170 subject trial was that topiramate, again, had a significant effect compared to placebo in being associated with end-of-study abstinence. So we had a pilot trial, replicated with a trial that was about 3 times the size, which was great, but still we weren't independently replicated until 2013, when Bankole Johnson and his team at the University of Virginia published their results of their trial of cocaine for the treatment of cocaine use disorder. And what you see here, instead of looking at end-of-study abstinence, we just have weekly mean proportion of cocaine non-use days per week. So did you use cocaine or not during a period of time during the week? And we have this is data with missing ignored. This is data with missing interpolated back to the baseline. In either case, there was a significant effect of topiramate for the treatment of cocaine use disorder. So that's wonderful. But where does this go from here? Probably nowhere. There is no drug company that's going to support the use of topiramate to get FDA approval. We hope maybe someday. But that's what we have for topiramate. Now, it's not really the end of the topiramate story. As I talked about, there is some evidence showing that long-acting amphetamine has efficacy for the treatment of cocaine use disorder for the reasons that I talked about. This is John Grabowski's first trial, where he looked at adding a low dose of amphetamine, 50 milligrams of long-acting amphetamine, and then doubling it in the middle of the trial, or the higher dose, 30, double up to 60. This is proportion of cocaine-positive urines. In the high group, you see a significant reduction during that time. So long-acting amphetamine works. Unfortunately, John had to stand up and talk about this at the height of the methamphetamine epidemic. And so it was hard to take him seriously, even though his group actually looked at long-acting methamphetamine for the treatment of cocaine use disorder and came up with very similar results. 81 subjects, 3 groups. Short-acting methamphetamine, long-acting methamphetamine, placebo. This is proportion of cocaine-positive urines. This is your high dose. This is placebo and, immediate release amphetamine. And this is long-acting methamphetamine. Completers versus all data. Again, no difference between those 2 outcomes. So there's a nice literature supporting the use of long-acting amphetamine or methamphetamine. My friends at Columbia, Francis Levin and John Mariani, wanted to go ahead and combine data from John Grabowski and his group and our group, and so combined mixed amphetamine salts, long-acting amphetamine, plus topiramate for the treatment of cocaine use disorder. The idea being, topiramate has that effect, that GABA effect in the ventral tegmentum. It may reduce dopamine release in response to the long-acting methamphetamine, or amphetamine in this case, rather. Long-acting mixed amphetamine salt, again, reducing the high and maybe making the amphetamine less abusable. In any event, they combined 200 milligrams or 300 milligrams of topiramate, 60 milligrams of mixed amphetamine salts, ran people for 12 weeks, and what they found was that not only did that combination work, but it worked better in patients who had more severe cocaine use disorder. And they divided up the severity by looking at patients who used for 0 to 8 days prior to randomization, 9 to 15 days, or 16 to 28 days, and saw that the effect of topiramate plus a mixed amphetamine salt was higher in patients who had more severe use. So that trial was published, and then Francis and John invited us to collaborate with them in a multi-center replication trial, this time entering only people who had that higher amount of cocaine use at baseline. And this is the result that just got published actually last month in Drug and Alcohol Dependence. And what it showed is, looking at the proportion of patients with 3 weeks of continuous abstinence, again, 12-week standard sort of topiramate trial, 200 milligrams, I used the dose that we used, plus 60 milligrams of mixed amphetamine salts. If you look at end of study abstinence, 14% versus none, so significantly better there. If you looked at any 3 weeks, again, you saw the difference. So combination of topiramate and mixed amphetamine salts is potentially efficacious. All right, that's all I have to say about topiramate. That's where we stand. I've also looked at cocaine withdrawal, looking at using an instrument called the Cocaine Selective Severity Assessment, another gift from the Center of Studies of Addiction. Sat down in Joe's office. He had this instrument that he developed along with our nurses that measured cocaine withdrawal, threw it across the desk to me and said, "Kyle, go do psychometrics with this." And I said, "What are psychometrics?" He said, "Go see Arthur Alterman." And I did, and I worked, and I found that this instrument is really good at predicting who is going to do well in cocaine treatment. And I'll show you that in a minute. But what it does is it measures cocaine withdrawals. It's an 18-item measure, 0 to 7 scale, appetite, sleep, depression, irritability, all those symptoms measured up. Cocaine does not have a medically significant withdrawal syndrome, but it does have psychologically significant, whatever you want to say. It predicts outcome. If you come to treatment with more severe cocaine withdrawal symptoms, you are really, really unlikely to do well. And this we've seen in just a number of different trials. For instance, if you look at retention in Anna Rose's coping with craving trials, and you looked at people with high and low CSSA using 20 as a convenient cutoff, you'll see significantly more dropout in patients, or poor retention in patients with high CSSA scores. You can go down to the VA and look at our addiction recovery unit retention rates, significantly lower in patients with more severe cocaine withdrawal symptoms. In all the medication trials that I've run at the CSA, I always measure the CSSA, so we were able to combine data and show that in our medication trials, if you looked at people who achieved end of study abstinence, people that came in with more severe cocaine withdrawal symptoms hardly ever became abstinent at the end of treatment. And if you look at detoxifying patients with cocaine and alcohol dependence, just a simple 1 week, show us that you don't use cocaine, show us that you don't use alcohol, and again, if you have more severe cocaine withdrawal symptoms, it just doesn't work. So, one of the biggest problems we have in identifying medications for the treatment of cocaine use disorder is our patients are different. And we need to understand how to identify patients that do better with medications. And the CSSA may be one way to do that. So maybe you're sitting there thinking, hey, what about topiramate and CSSA scores? And sure enough, yes, patients with more severe cocaine withdrawal symptoms measured by a CSSA, in this case the score is 18 or more, did significantly better on topiramate than they did placebo. That was where the main effect was in patients with more severe cocaine withdrawal symptoms. So this work continues. We want to use this with our medication trials. We want to be able to identify patients who would do particularly better in one trial versus another. All right, our current trial, metirapone and oxazepam for cocaine use disorder. Mick Goders from LSU has been looking at this combination of medications ever since I was a young fellow.
A child.
since 1990. Why? He was obsessed or interested in the adrenocortical stress response system, and felt that if he intervened in that, especially in animal trials, if he blocked cortisol, he could get animals to stop self-administering cocaine. So he's interested in that. That's where the metirapone comes from. Metirapone is a cortisol synthesis blocker. And so metirapone is very effective in blocking cocaine self-administration in animals. He got interested in oxazepam, which is benzodiazepine, sort of as an aside. It turns out that benzos actually do reduce cortisol in release in response to stress, and also will stop animals from self-administering cocaine. So metirapone and oxazepam, put them together actually in a single capsule and see if you can't get some effect. The pilot trial he ran, 45 subjects, about my size type trial, ran a high dose and a low dose of metirapone, 500 milligrams or 1500 milligrams, same dose of oxazepam, 20 milligrams a day. Looked at cocaine use by urine drug screens, lower in both groups, a lot lower in the high dose group. So that's the dose that we're going to follow. We're going to do high dose metirapone plus oxazepam for the treatment of cocaine use disorder. We're going to run it in a standard 12-week outpatient clinical trial. 80 subjects, 4 sites, and that's what we're going to do. And we're going to see if Nick's dream is going to come true. Okay, that's all I have to say about cocaine. I'm going to wrap this up in the next few minutes talking about my work with opiate use disorder. I'm going to not talk about the work I've done with the injectable buprenorphine and the injectable Vivitrol, but rather go right into withdrawal. Taking care of alcohol withdrawal and enabling patients to get on to extended release injectable naltrexone is critically important. Extended release injectable naltrexone is an opiate antagonist. You have to be not physically dependent in order to get it, or it's going to make. But if you can't get to that point, and if you take the injectable naltrexone, it is a very effective medicine for the treatment of opiate use disorder. Every bit as effective as buprenorphine. But you've got to get people into detox. So, in the old days, that was easy. You put people in the hospital, you gave them methadone, you gave them buprenorphine, you tapered them for 7 days, but at the end of that, we had to wait another 7 days to get the methadone and the buprenorphine out of the system to give them naltrexone. And during that 7 days, anything can happen. CBH will kick you out of the hospital on the last day you get medications. So you're done your detox, you're on the street. That's the problem. Because once you hit the street, you're not going to get your naltrexone shot. Almost 90% of the people that get sent out after detoxification do not get their naltrexone shot. That's a problem. So what we do now at the VA is that anybody who comes to us and expresses an interest in getting on injectable naltrexone gets a non-narcotic detox. So at the end of 7 days, we can give them a Vivitrol shot. Because people can't stay on our inpatient unit for more than 7 days without going absolutely crazy. So they often ask to leave AMA. So that's what we want to do. So what do we do for a non-narcotic detox? Clonidine, a blood pressure medicine. It blocks alpha-2 receptors and therefore reduces the release of adrenaline, which is the big problem in opiate withdrawal. So you give them clonidine, they don't put out the adrenaline, and they do okay. The problem is, you can't give them enough clonidine to stop withdrawal symptoms without dropping their blood pressure and making their heart go so slow that they get sick and faint. So you use lofexidine, which is a selective alpha-2 agonist found mainly in the central nervous system, so it doesn't cause blood pressure and pulse rate drops, but it's not a great medicine because it doesn't really do much for pain and anxiety, which are the big reasons why people drop out early when they're trying to get through opiate detox. So pregabalin, which blocks voltage-gated calcium channels and is actually approved for the treatment of neuropathic pain, also used off-label for anxiety, is the medicine that we're going to add to lofexidine to improve the efficacy of lofexidine and get people detox. Lofexidine is FDA approved. Big trial, 264 people given lofexidine. If you look at their subjective opiate withdrawal scale, it drops significantly compared to placebo. Wonderful, looks beautiful, doesn't it? Only 37% of those lofexidine patients made it through the trial. The vast majority dropped out because they were uncomfortable. They were in pain, they were having anxiety. So we're going to give them pregabalin based on the work done by our friend Evgeny Krupitsky in Russia, who actually looked at a trial comparing pregabalin to a clonidine detox. See who was left after a 7-day detox. Significantly more people left after pregabalin, used significantly less medicine for pain. So we're going to combine pregabalin plus lofexidine for the treatment of opiate withdrawal. We've got 3 centers, Penn, Columbia, and Mountain Manor, which is down in Baltimore. 90 subjects, 7-day withdrawal management. Our primary outcome is getting people successfully detoxed and getting them on injectable naltrexone. Again, you don't detox somebody and send them out for drug-free treatment because they're just going to relapse. We need to get these people on to extended release injectable naltrexone. All right, so that is 20 minutes of my 25 years here. Cocaine's still a problem. We still need medication, so I've got a job for a while. Biomarkers may help target appropriate patients. We hope that cocaine withdrawal symptoms can be useful in that respect. And again, we're going to try to get people on extended release injectable naltrexone as quickly and as easily as we possibly can.
Excellent.